All right, so today this is the things you get titled on the slide screen and then the title off of Echo. Sometimes they match perfectly and sometimes they don't. This is the shortened version with the subtitle, but basically today we're going to be talking to you guys about kind of the intersection of pregnancy, substance use disorder, opioid use disorder, and parenting and recovery. So we're going to cover a lot in a hopefully efficient short period of time without blasting through it too fast, because it actually really does matter a whole lot. And we've got a number of people joining us today who live this every day, understand why this matters so much, all the people that this impacts, and why it's so important that we get it right or as close to right as we can. So I didn't update it, and Veronica didn't add herself, but it's me and Veronica here who are the presenters for today. Neither one of us have any disclosures. And so basically, these objectives kind of make me giggle a little bit because they're rather lofty, but increase awareness of upstream contributions to our downstream challenges related to women and substance use disorder, understanding the impacts of the external environment and the development of substance use disorders and the vulnerability to substance use disorders with the environments that our people are encountering, we people and our people, all the people, and then how our role extends beyond our four walls to promote prevention of the development of substance use disorder. So the work we do in our clinics is vital, but it's more than just what happens within our clinics that matters, probably matters more. So just off the bat, get it out there. ACOG and SAMHSA discourage tapering and cessation of medication for opioid use disorder during pregnancy and after delivery. Attempt to avoid NAS or NOWS, and that's neonatal abstinence syndrome versus neonatal opioid withdrawal syndrome. And just giving a nod to a minute to there's a difference between those two guys. Abstinence syndrome is any substance, and then the NOWS is specific for opioids, because neonates can experience withdrawal from a number of different substances, not just opioids. And trying to avoid that occurrence is not a reason to stop medication. And then I already kind of covered this. NAS, it's any substance. So it could be nicotine, caffeine, meth, cocaine, gabapentinoids. There's so many different things that the neonate could have been exposed to, that's going to have withdrawal syndrome. And a lot of those withdrawal symptoms overlap from substance to substance with opioids. So the increased tone, high pitched cry, difficulty to console is not just opioid withdrawal in the neonate. It could be, quite honestly, any of those substances. As we currently understand it, evidence demonstrates that opioid agonists are the gold standard. We do have this lovely tool in our toolbox of naltrexone. Switching a patient during pregnancy from an opioid agonist like methadone or buprenorphine to naltrexone. We don't have a ton of evidence for it, but someone who is on naltrexone and becomes pregnant, we typically are not changing their course of treatment, because when you have someone who's stable, you don't really want to do things that might make them unstable. So when they come to us with what they're on and they're stable, we're not going to mess with it. And then the neglected or overlooked substances, because they just don't get the press that they used to back in the day, or maybe at some point in time. We were really hardcore about tobacco and nicotine exposure and really worked hard. And I think in some ways we maybe felt like we were having a hard time being effective. And so we're like, okay, I just want to make certain you get the care that you need. And I'm not going to beat you up about the tobacco anymore, but if you could just cut back a little bit, and then we don't bring it up again. But it's vitally important. These substances do have big impact on the developing neonate, that brain, as it's growing in utero, and then how it is impacted, that exposure in utero impacts continued brain development and increases risks in these individuals after they've been delivered and they're walking around and growing up on the outside. Increased risk of issues like using the substance themselves, educational challenges, difficulty with executive function, things like that. So we need to not overlook other substances a pregnant or contemplating pregnancy individual might be exposing themselves to, and thus a potential fetus, because a lot of pregnancies are unplanned. So talking to people about these things before they get pregnant is very important.
Especially, I think caffeine intake is one that we overlook a lot as well.
Yep. Yes. And there are actually some studies that suggest that excessive caffeine intake can lead to pregnancy complications like preterm contractions and labor. So recognizing the impact of substance use disorder and opioid use disorder, it's present before the pregnancy, which is I was mentioning that talking to someone pre-pregnancy counseling about substances they might be using or exposed to, or if they're at risk of continued use or harmful use, high risk use of different substances. It will impact that pregnancy, but it's also going to be far reaching into the future lives of both the mama and the infant. And we need to take that into account of the bigger picture and not just the snapshot that's happening in front of us for those, hopefully 40 weeks, maybe a little less, maybe a little bit more, and then the lifetime of that mother-child dyad as they continue into their future. And recognizing as well, there is much more at stake than what we are putting on a prescription pad. Our impact goes far, far further than what we're prescribing, though what we are prescribing makes a difference. That we're addressing concerns, whatever it is, whether we're addressing their underlying depression, anxiety, or not, getting them the care that they need, whether it is pharmaceutical or non-pharmaceutical. We're going to use a couple of case studies to kind of illustrate the stuff that we're talking about during today's lecture. This pulls from my New Mexico days, thus the Lordsburg Queen. Just amazing, amazing, just beautiful individual. She was probably not too far into her 20th year when I got to meet her. Her first pregnancy, 20-year-old, started her prenatal care as an inmate at the Lordsburg Detention Center. Lordsburg is just this tiny little town in the middle of a dusty exit off of I-10 with not very many inhabitants. There's not a lot of resources there. But she first presented to us as a inmate from the detention center at about 17 weeks. She came to us not because she was pregnant, but because she was withdrawing and pregnant. So I was working in an OB clinic at that time and providing substance use disorder care. So she became my patient for both prenatal care and her substance use disorder. In working with her, finding out that her original charge, what started her entire career with the judicial system, was she was 18 years old and hanging out with a friend who was 17. They were in a group of friends. She was 18, not the only 18-year-old, but they were drinking and they got busted. She was charged as contributing to the delinquency of a minor. She was the only one who was charged, but she's not the only one who was 18 or older. She may have been the only female who was 18. Everybody else was either underage or male who was involved in that bust. All the rest of her legal issues came from substance-related probation violations. So she was not holding up liquor stores. She was not running people off the road. She was not, beating people up. She had been partying with friends, got a charge, was put on probation, and would test positive for different substances and be put back in jail. When she was brought to that first OB visit and a few visits after that, she was shackled, both ankles and wrists, for someone whose only charge and subsequent violations were related to using a substance. Never anything violent. She never tried to run. None of that. And it was kind of not funny, but funny because it's where we were. People were breaking out of the detention center all the time. It was a little bit of a joke. And she never tried to do that, but she showed up in shackles anyway. She had detoxed basically in the Lordsburg Detention Center. She had been off of opioids by the time she presented to me. She had been in there for a few weeks, and but she was having strong cravings. And we talked about what she wanted to do, and the cravings were unrelenting and unmanageable. And she wanted to get on buprenorphine. We talked about what all we could do, evidence, risks, benefits, all that kind of stuff. And with informed consent, she elected to initiate buprenorphine. We were able to stabilize her on 16 milligrams. Cravings were gone. In the controlled environment of the detention center, they provided her medication. She got her daily doses. She got the appropriate amount every day. I got to see this really beautiful, amazing, just cute as she could be. She would always fix her hair in the cutest ways. Even though she's in the detention center, she would do these funny little buns and braids, and come into the office just bouncing in with her growing belly. Just this really vibrant, engaging individual would come for her visit. She had a lot of good insight, a lot of understanding of her situation, goals and aspirations for what she wanted to do, following her, meeting her requirements of being incarcerated and becoming a mother. Also, it was nice to see that, the same warden kept bringing her for visits. Interestingly, this warden was female, probably one of about 2 females they had in the system down there. She would bring her to her visits, and the shackles went away, which was lovely to see, because it was just heartbreaking to hear her shuffling down the hall with those stupid things on. But also just the trust that seemed to develop between this warden and her, and this understanding of this sweet girl was not going to run anywhere, so we don't need the shackles. It was actually really humiliating to see this young girl in her orange jumpsuit with chains on her wrists and ankles. I was happy when they were gone. She did well throughout her prenatal care. She had probably at about 35 weeks come in for a check, and I had diagnosed a primary herpes outbreak at that time, put her on medications. But because when she presented at 37 weeks to labor and delivery with contractions and a changing cervix, lesions were still present. So we had to set her up for a primary low transverse C-section, because of those lesions still being present. We don't want to do a vaginal delivery in the setting of those lesions on the genitalia. So we did a C-section, and she had this cute as could be baby boy. And then my little bitty hospital out in New Mexico, we did not have an eat, sleep, console model, but we were small and very facile. So we on the fly, we're doing eat, sleep, console for this dyad. He did fantastically. All of his Finnegan scores were below 6. That's almost like that. It is. It's not just like that's a normal neonate. He did beautifully. She was discharged. We did the required 5 days of monitoring for him. She was discharged at day 3. She had come in from the jail. She had no clothes. She had no nothing. She was being put on furlough, meaning she didn't have to go back to the jail after she was discharged. She got to stay with the baby and was going to go home with the baby on house arrest. So that had been arranged. She had nothing. She had nothing for him. She had nothing for her. So a friend had come by and took her out shopping and took her out for dinner. And so she was gone for several hours. And she came back completely appropriate. And everybody's like, oh my God, did she go and use? No, she didn't. That's not why she was gone for a while. She had a nice steak dinner. She was very hungry when she left the hospital. And she bought supplies for her baby and herself, so that when she went home, she wasn't going home in a hospital gown or her orange jumpsuit. During her absence, though, his scores jumped up, and we did some PRN dosing of morphine. He got 2. When she came back, those scores went back down below 6, and we did not have to use any more morphine to manage his withdrawal symptoms. So eat, sleep, console model is you're in a low stimulus environment, so we're not flipping on the overhead lights. We're looking at baby, not doing the Finnegan scoring. The hospital was still doing them, so it was nice to see that how well he was doing. But with eat, sleep, console, you kind of pull the Finnegan scoring in when you're not effectively eating, they're not sleeping well, and you're having difficulty consoling them. You can bring those Finnegan scores in and kind of get an assessment. But if your kid's eating, sleeping, and you console it, then you're on the right track. Ways in which we help the babies regulate themselves is breastfeeding. There just seems to be something really amazing that happens there. Probably the skin to skin, just the proximity, following baby's cues for all needs, and then treating mother as baby's medicine. Mom is medicine. Mom is what's going to, she's been connected to him. We just had to cut an umbilical cord, so we're reconnecting them externally, allowing that to happen, and encouraging that to happen, and not taking baby from mom, bringing it into nursery, separating them. So making certain mom and baby are in contact as much as possible, as often as possible. And that's the rooming in. And then looking at non-pharmacologic interventions, swaddling, again, that low stimulus environment, breastfeeding, different types of things to help keep those two in close proximity. This model results in significant reduction in the length of stay. There have been a number of studies that show it going from like 28 days to 3 days or 5 days. A lot of hospitals have required 5-day stays. sometimes we do let them go sooner than that, but 5 days is pretty typical. But going from, nearly a month or more to less than a week is a very significant reduction. It also results in utilization of less opioid agonists like morphine. Some hospitals use methadone for those withdrawing babies, but we are not exposing these neonates when we use the Eat, Sleep, Console model to opioid agonists, like directly, not just through your umbilical cord, but now we are going to give you your own dose of some type of opioid, which is nice to see. The other thing with the breast milk, a lot of people are like, well, if they're breastfeeding and they're on buprenorphine, it's going to go into the breast milk or any other type of opioids. Buprenorphine itself is a very large molecule. Provided you guys the molecular weight in case anybody wanted to know how many Daltons buprenorphine is. It doesn't pass into the breast milk easily. Does some get through? Yeah, a little bit. But by and large, we are not talking about a significant level of buprenorphine that passes into the breast milk. So it's not a matter of they're getting more exposure through the breast milk. And that's why we see less withdrawal symptoms in breastfed neonates. That's not what it is. It's some of those things that we just can't measure all that well. There are some enzymes and other things that are present in the breast milk that are probably mediating this effect. But breastfeeding is one of the best interventions when it comes to managing withdrawal symptoms in these babies. So on house arrest, that furlough, got to go home with baby. Lordsburg was about 45 miles away from my clinic. And again, Lordsburg had no resources. So connecting her to safer and healthier resources in her community was challenging. She had a violation. I think she had used or something, probably opioids. She tested positive with her parole officer or something, but I lost a follow-up. So I don't know exactly what happened and why she ended up in jail, but baby ended up with the maternal grandmother. So again, things outside of my control in my office and what I can do and prescribe and manage, there were elements in her community that did not set her up for success, which is kind of a sad point in the story. And I hope it got happy, but lost follow-ups. I don't know exactly what happened with that family. The war on drugs has caused a significant rise in the number of women who are incarcerated and their access to adequate drug treatment. 40% of those convictions are related to drug-related crimes. 7% for public offenses like drunk driving, liquor law violations, 18% because of violence. So these women are treated like my patient, nonviolent crimes, and she's shackled, as though she is some type of dangerous threat to society when they bring her out of the jail. So incarcerated women are treated differently. Their sentencing is heavier. The way in which they're managed is more punitive. When you compare women to men, the offenses and the sentencing, it's different. Additionally, women of color are significantly overrepresented. When you look at Black or African-American women who are incarcerated, 30% of that population are African-American. 13% of the female population is African-American. So that is a huge overrepresentation in our incarcerated population. Hispanic women, 16% versus 11% for incarcerated versus the census of our demographics of the United States. There's probably, granted, getting our census information and then COVID hitting up on it. I think these are all like from 2020 type, pre-2020 numbers. So they may have shifted some, but not much. Graphs. Sorry, you guys can look at them. These slides will be available to you. I'm not going over these graphs. You guys will get the slides in the resources page. And if you want to study those in detail, feel free to do so. So we think about these women and how they're treated in prison, but then we remember also they aren't just women who've committed crimes that they must pay for, right? They got to suffer the consequences of their actions, whatever. We can have another session about that. They're women. A lot of them are mothers. 2/3 of them are mothers of a minor child, and they're not able to parent their children because we've got them locked up. 1.5 million children have a parent in prison, whether it's a father or a mother, but 1.5 million children have a parent in prison. More than 8.3 million children have a parent under correctional supervision. So they're not in prison anymore, but they're still on probation or parole or whatever. And then more than 1 in 5 of these children is under 5. And I think we all know how critical those early years are, those formative years. And these children are living in a household where there is a black cloud over it all the time. Parents are having to go in and report. There's always the threat of somebody's going to have to be, reincarcerated. There's a probation violation, or they've picked up another charge for, I don't know, because they're trying to get their kid to their after school function, or they're trying to get to the pharmacy to pick up a medication for their kid who has an ear infection, and they get pulled over and they have a revoked license. They're going back into jail. Kid never gets their meds. Parent doesn't come home. What happened? We find out days later. So you can imagine the uncertainty that a lot of these individuals are living with, and how these upstream issues of how we manage some of the infractions that people will commit in our society are handled and dealt with. And it has consequences that really impact the parents and the children who are going to become parents one day themselves. Additionally, the Welfare Reform Act bans those who have felony drug convictions from federal cash assistance and food stamp programs. So there's more words there. It's a lot of words. Basically, I'm just going to boil this down. Well, Veronica does a better job of it, because it was actually Veronica who helped me put this slide together. So when we have these situations, Veronica, where these convictions preclude individuals from accessing these resources, what does that look like for these families?
So essentially, it looks like they have to go through so many different hoops in order to get the benefit, get the SNAP benefits, or they don't get them at all. For instance, I was working with a pregnant mom who she already had 2 other previous children in her care. And because she had a drug felony and could not prove that she completed an inpatient treatment program, they would not offer her any assistance at that time. I believe that it's changed since then. This was a few years ago, but and they've made it more lenient to where now, if you've ever had a drug conviction, that you at least have to show that you've completed a program or you are currently in treatment, and it can be outpatient treatment. So there's many different hoops, and in order to, if anybody has had any encounter with the DHS system right now, just to get food stamps already for your family is near impossible, because they are so backlogged. And so when you add the barrier of that you have a drug conviction, and then having to get yet another verification approved, it leaves a lot of moms and a lot of families without food.
And then you've got a situation where parents are not able to meet their children's basic needs because they don't have access to resources in order to meet those needs. And then that turns into a DCS referral because somebody saw, that the children didn't have what they needed, or just it is a vicious cycle that feeds on itself, so that we have set people back, and then we are not making it easy for them to access resources in order to help advance their situation and get out of the cycle. It's almost as though once you get in the system, you stay in the system. It seems to be a miracle sometimes that people are able to pop out of it and get out of the system cycle. So there are programs set in place that are there to help individuals move forward, but then we put barriers on that. So some of the most needy who could really utilize these resources to help them get out of a negative cycle, they just keep getting pushed back in it. So programs that are designed to lower recidivism and help justice involved individuals actually have barriers built in that they can't do what they need to do. So they stay stuck in these cycles. So you can imagine all of that sounds really stressful. It's really stressful to even just say all those words, much less live that life of where you've got all of these competing requirements on you. And then how, like, your license is revoked. You just got out of jail for spending 60 days for driving on a revoked license. You're back on rent now. Like, you owe money to people for this. You owe more money for fines because of just being put back in jail and all the things. And you're just like, how am I supposed to do all of these things? That stresses you as the individual. And then you've got this family and there's uncertainty. I mean, children thrive in an environment of routine and predictability. And we've just described to you a very non-routine, not predictable environment. So these outside factors increases stress. So increased exposure and vulnerability, just because of these stressors, it's a setup in our body's stress response system to lead to things like overdevelopment of the amygdala, to lead to all the wonderful adverse childhood experiences that lead to increased risk of medical morbidity and mortality, which includes vulnerability to substance use disorders and severe substance use disorders. So the social determinants of health that generate and support chronic and prolonged stressors are predictive of substance use disorders. And we've just described scenarios that are part and parcel to these chronic and prolonged stressors. So we've got a mother who has a substance use disorder and she is pregnant. We are growing the next generation of individuals who are going to have to figure out how to navigate this incredibly stressful situation. And we have set them up before they even draw their first breath for being incredibly at risk and vulnerable for the same things that their parents have just experienced. So part of our job as addictionologists, as case managers, as peer recovery specialists, as counselors and therapists, as doing the work that we do is prevention. And we are in a system that helps perpetuate the thing that we are trying to stem. So just thinking about these upstream, downstream. So chronic stressors include concentrated poverty, systematically thwarted opportunities. I read that somewhere. I had to write it down. Basically, we're talking about discrimination, incarceration, loss or separation from parent at an early age. Again, we're getting at some ACEs here: emotional, physical, sexual trauma, parental divorce or conflict, neglect, isolation, housing, and food insecurity. I don't know. I mean, yeah, most of our patients could tick every single one of those boxes. And it's something they're experiencing right now. Some of these things they experienced as children, now they're experiencing them directly as adults, and their children are also experiencing them. So we've got a system that is perpetuating itself. Stress response. So activation of stress response linked to craving of substances. So there were studies that were done. That's what all these little numbers are. You guys can dive into those. So when we look at that, we want to be thinking about, you know, what are some things that we can do to direct these kiddos and these families out of that. So they've done some studies to check that out. And we do see that when stress response is activated, it does link directly to craving of substances, exposure to stressors, and next day alcohol intake are definitely linked. And that number 8, there's a study that illustrates that. And then some studies that were done with rats show that rats who are substance exposed and socially deprived will actually choose interaction over a substance. So if they're in a situation where they can, like, I can go hang out with some other rats and I've not been allowed to do that in such a long time, or I can go lick on this cocaine laced water bottle, they're going to go hang out with the other rats instead of licking the cocaine water bottle. So there are some studies that indicate stress response and use of substances are definitely linked. So when we think about how are we going to improve environments, finding ways to not stress people where it's not necessary would be really helpful. I'm going to let Veronica take them here.
Okay, so a little bit, I know we're kind of getting close on time, but I did want to touch on the parenting and recovery. And I took this, in our clinic, we've done a couple of parenting and recovery groups for our patients. And this is one of them, just the nurture the child within. And I say that because so often when our patients or people with a substance use disorder, when they go into parenting, especially when they meet the stabilization phase, that it's just, okay, what now, right? That they're done with living the crazy lifestyle. They've stabilized, however, but they have older children now. And after they're pregnant and they come into their motherhood, nobody's taught them the skills of how to negate some of the consequences that have happened, or that the children's adverse childhood experiences. So a big one is always what we call in recovery taking a self-inventory, nurturing that child within. Like, why? So we carry unresolved issues from our childhood into our adulthood, right? And so people that use substances to avoid whatever unresolved issues are, they are still there in adulthood when the substances are gone. So what do we do though? We do more of the same thing. What doesn't work, we're hoping it eventually will work, right? That same definition of insanity over and over again, expecting a different result. So, and I'm not going to spend too much time on this. This was just a slide that I just got out of, but was a good segue into being able to parent treat. So I try to tell my girls, or even, and I don't mean to say just girls, men too, that are single parents, that whenever you are trying to figure out how to do positive discipline or how to parent your child, start with you first. Start with the grace of you first, and how you wish you were treated at one point, and change your perspective. So you get to choose this time your new pattern of feeling, thinking, and acting. We don't have to take away from how we were brought up as children and parent that same exact way. So breaking the cycle, right? Correction does much, but encouragement does more. Again, this was just there was so much more that came to this, an awesome little, you can probably look it up. It's Positive Discipline and Recovery. And they have a lot of like worksheets and different things, like you say this, but say this instead. So the whole praise versus encouragement, and teaching them how to be a parent to their 5 to 10-year-old. And encouragement is literally the process of building that courage. The people in recovery are trying just to build their courage up to be the mom, the employer, the daughter, the functioning person in society. So providing an environment where others may be inspired to examine their behaviors because they know will not be judged is something big that we try to facilitate for them here in clinic or wherever they are out in the world, that hopefully that somebody is providing them a safe place. And then in turn that translates into their home and translates into their parenting style. And so, when people feel encouraged, and you can replace people with children, when people feel encouraged, they handle the situations differently with more dignity and respect. And then the reason why I kept people and didn't put kids, because I thought kids, and I was like, well, kids don't have dignity and respect. And I'm like, well, yeah, they do, right? They do. And it's us to teach them that, but it's also us to model that for children. And one of the biggest things for people in recovery that are just relearning or learning for the first time how to parent is grace and showing themselves dignity and respect, and that will translate to their child.
So this kind of helps illustrate kind of the parenting piece. We've got one of our patients here, 32-year-old female. She's a G7. She's delivered 4 kiddos. Her last kiddo, because she has the number of kids, and she has 2 currently in custody, hers full custody. They're her children. She's raising them. They're early school age, toddler age. And then she's got 2 older kiddos. So this is her 5th child that she just delivered last few months. That early in the pregnancy, she was like, I have so many children and I don't know that I can do this. She contemplated adoption, but then in the end decided to keep the baby. But she was having some substance use stuff. She came to our clinic, she stabilized. She has been free of illicit substances for some time now. But when she delivered, I do think she tested positive for marijuana. She ended up not retaining the child in her custody. We've kind of been a little bit back and forth. And what it really gets at is right now the case is closed, but she can petition for the child to come back. She has unsupervised visitation. It's been back and forth. Can you tell? Like, we've been a little bit here and then we've gone back here. She is someone who speaks up. Like, I'm overwhelmed and I'm struggling and I really feel like I'm not doing what I need to do for this child. She is a very good example of a parent who has not gotten to through parent a child. The age of this baby, she has not parented a child at this age. She regained custody of her older children. She did not have custody of them during before I turned 1 period. So she's very uncertain about her abilities to take care of this child because she's not cared for this child at certain points during its infancy. She feels like the baby doesn't turn to my voice. The baby, I don't know how to console the baby. The foster mom, she knows how to do these things. I feel less than. Never mind, she is parenting 2 other children. They're different age children than this child, obviously, but she is lacking confidence in her ability. She feels scrutinized. She feels like everything, and she's not wrong, every little thing she does is evaluated, picked up, looked from every single angle, and criticized. And it has her on pins and needles. She already deals with anxiety, and this has just driven it to a whole new level of anxiety, where she's being watched so very closely and feeling uncertain anyway, as most mothers do. And one of the things when you're parenting a child, and you may have 7 babies running around and you parented none of them, and you've got the 8th baby, and you are taking this kid home and you're going to parent this child. It doesn't matter how many you birthed. This is your first time parenting. It is a whole different ball game of like, I've had all these children, but I do not know what I'm doing. And people looking at you, it's kind of like the 3-year-old who looks like they're 5. And people expect the 3-year-old to act like a 5-year-old because that's what they look like. So scrutinizing people through a lens of expectation that isn't appropriate for the level at which they're entering this situation. It was really lovely. We had a program, I'm talking about New Mexico a lot today, in New Mexico, where we had nurse visitors to our families. It started off with first time babies. They got these services, didn't matter. Socioeconomic didn't matter. If it was your firstborn, you got these support services. And they were able to grow the program where I could actually engage this program for patients of mine, even if they were having their 7th child. If it was their first time parenting sober, they got these services. So recognizing what our families are going through and the kind of support that they need really makes a difference. So she is a really good example of someone who has parented, but is new to parenting an infant, very uncertain, highly scrutinized, and it's making her transitioning into the parenting role all the more difficult. She comes to us and is very open about, very transparent about her challenges, her difficulties, her uncertainties. She sometimes will articulate that to DCS, and I think that's made them kind of tighten down on her a little bit. So we're helping her understand where you talk about what to get the services that you need. And maybe you don't need to tell your DCS case manager that you don't know what the hell you're doing, and maybe they should just take the baby. So we're working through some of those things with her, but she is someone who wants to use the resources available to her and use them wisely. We're just helping her articulate her needs in a way that gets them met, and having people not freak out and slam down on her and just take the kid away, because she does show huge promise for being able to parent this infant and grow a strong bond with her child, because she's done it with her other children. I'm going to skip this part because of interest of time. I need to go back one. So we've talked about a lot of things. And what I want to kind of end on is thinking about us and our role and how we engage, in particular, this very vulnerable population. Pregnancy is a vulnerable state. Being pregnant and having a substance use disorder, I mean, just think about the hardcore judgment that you're dealing with every single day that you wake up and look in the mirror, as well as the people that you encounter. So starting to think about these individuals as human beings and not our patients, which I know all of us do anyway, so I'm preaching to the choir. But thinking about, like, are they diverting? Are they taking it as prescribed? What does the UDS show? How am I collecting? All these things about, they're important. They're very important. I don't want to sell those things short. They're very important, but I don't want us to lose sight of, there might be ways in which my patient, like, are they taking the full dose? Are they giving some to somebody else? If they test appropriately, confirmatory, point of care, whatever, and they're keeping appointments, they're progressing through probation, they're meeting milestones, they've got a job, they're keeping a job, those things actually, I would argue, matter more than maybe they snort a quarter of their pill. We'll work on that behavior because it's a behavior, but maybe they snort a quarter of their pill, they're taking the rest under their tongue, they're doing everything else, like meeting them where they are and helping them move forward into healthier patterns and behaviors, and not being part of a punitive system that gets caught up on some of the things in the first part of that bullet point. Are they meeting milestones that indicate someone who's doing their best to move forward in recovery? Because they're human, just like us, and we all kind of do things that maybe aren't the best choice that day, that moment, but we get another chance another day. Children are confronted with adversity, because who have a safe, stable, nurturing relationship with at least one adult fosters positive outcomes. So this is the resiliency piece. We all get caught up on the ACEs, but there's also a resiliency piece. So you experience some crapola, sucks. I don't have a shield or a magic bullet to keep us all safe from, because trust me, the first people who would get it would be my children. And then I'd let your children have it too. But if they've got a stable, nurturing relationship with at least one adult, that really increases their ability to navigate these challenges and adversity. And these supportive relationships buffer that stress response by allowing them to be more successful in confronting stressful situations. Mothers with a substance use disorder probably had their first hit in setting them on the path that they are on and how we've encountered them when they were themselves in the womb. The generationality of what we see in our patients is a real thing. Their mother may have experienced physical abuse in the home, may have been in a toxic environment, maybe had a substance use disorder herself, came from a home with substance use disorder back in the day when it was just alcohol, right? Just alcohol, it's huge. It's not just alcohol. That is one of those underexposed, evaluated substances that is within our families and homes. So we've got someone who's primed for a substance use disorder at increased odds of incarceration, poverty, poor access to supportive interventions, and she's sitting in front of us, already primed herself from the womb for what she's experiencing, and she's in front of us pregnant, and we are looking at the next generation. So doing what we can to increase fair, appropriate, compassionate, caring interventions and interactions with these individuals, it's vital. They're harboring the next generation of substance use disorder, and our behaviors can increase the odds that they can change their behaviors or we continue down the same path. So it's a community disease. Maybe it's a communicable disease, but it is a condition that we as a community, as a society, we can impact in a positive manner through the way in which we do the work that we do. That's it, coming off my soapbox. With 7 minutes to spare, we talked a lot, guys. Questions, thoughts, comments? Rick has put out there a ton of articles, so take a look at those, guys.
I just want to point out that also with that molecular weight that you mentioned about the breastfeeding, the same thing also applies with the transferring the buprenorphine from mother to the fetus through the placenta is less than methadone, and therefore with the long half-life of the buprenorphine that we have, we're expecting less of the neonatal opioid withdrawal syndrome after the birth. So
yeah, and it's I didn't have it in this, but when you look at severity of withdrawal, one, it's not a given that it's going to happen, because sometimes it doesn't, whether it's somebody's actively using fentanyl, roxicodone, whatever it is that they're getting out in the world, versus methadone versus buprenorphine. Methadone on the higher end of potential withdrawal symptoms, regular full mu agonist opioids, and then buprenorphine. So just utilizing buprenorphine itself as the opioid antagonist, you're going to have a lesser incidence and less severity of neonatal opioid withdrawal syndrome. So just even with utilizing that medication, you've already set the kiddo up to have a better neonatal course. Thank you, Cameron. Other thoughts, comments? We stunned you with science.
I had a question about nurses. Maybe I should know this. I don't know. But as far as nurses that are caring for these babies, I did take, this has been probably 15 years ago, 10 years ago somewhere, a class on NAS through the state. But the nurses that are caring for these babies, do they have additional training or anything additional that they're required to care for these little babies?
I am not aware of there being something specific. I mean, I think it's just part of nursing training anyway, like for utilizing the Finnegan scoring, and there might be some people on the call who know more than I do about that. Those who have been on an labor and delivery deck where most of the time, those are the nursing staff that's going to be engaging with these kiddos during this withdrawal period of time. So
I just wonder because I
Yeah.
know when I went through nursing school, I don't remember it being a big topic, if a topic at all. I took the class through a state program that I was working with foster kids. So I don't know. I just wondered that. And I've had a couple patients that have come through here at Detox and then engaged in one of our other outpatient programs, and both pregnant females, but when they had their babies, both of them had a lot of issues with the babies, and so and with the staff at the hospital. So I just wondered if there was like additional training for them there.
Morgan, because of the role that you serve, are you hearing anything back from your mamas or any engagement with nursing staff at the hospital where you're aware of they're getting additional training or?
From my understanding, there isn't necessarily any additional training that they're receiving. From what I'm hearing from my moms, it's still not up to par with where it should be. They still feel like they're being treated negatively, just because of, especially because I'm working with moms on MAT. So of course I have moms who are also, testing positive for fentanyl or testing positive for meth. But even our moms that are down to 1 milligram of buprenorphine are still being treated ugly at the hospital. So really there's not been anything positive. Now I do have some moms who have had positive experiences, but I am still hearing a lot of negative stuff.
Yeah, that's what I
And
think.
That's kind of what I
also,
gathered from those couple of ladies.
something else that I've been catching is that they look at these moms like in a lump sum. So like you might have 2 or 3 moms that have substance exposure on the wing that day, and they are putting things in those moms' chart, like maybe this information was from mom A, but it was supposed to go in mom B's chart. So they're crossing over and adding the wrong information to the wrong charts because they're lumping them all just together, like, oh, that's just a substance exposed child, that's just a substance exposed mom. So there's information that's supposed to be in one mom's chart, but it's getting put in a different mom's chart. So I'm seeing a lot of that type of stuff going on.
That's really disheartening, Morgan.
Yes, actually, I just caught one today. So I reached out and asked about it because we had a mom. She did have some issues with IV meth at the beginning of her pregnancy, but she's been doing really well. And it came up in her chart that there was a DCS referral made from the hospital because it said that mom admitted to IV meth use 2 weeks before she delivered. Mom said that she never said that and has not relapsed. So she does not know why that made it into her chart. So I reached out to the hospital and they said, well, there were several moms who had similar stories that were here at the same time. So maybe that it got put in the wrong chart.
The unfortunate thing is you
So-
put out that DCS referral and it's going to happen. Like there's no pulling that
Yeah.
back.
So we're currently trying to do damage control on that one for that mama.
That sucks.
Yes.
Yeah. So again, the work that we do and how it gets done, and just decreasing the stressors that we're exposing people to, and the necessity of like why it's so important that it's important anyway to get the right stuff documented in the right chart, but the downstream impact of that and what this family, this neonate, is going to have to experience. Hopefully it's one of those like open, closed in 5 days type of situation, but you don't know that because it depends on your case manager that you get from DCS.
Absolutely.
So that's a challenge.
Also, the processes at the hospital are not always cut and dry. We have policy and procedure for a reason, but you might have, like I had a couple months ago, I had 2 moms that were there at the same time. This one mom had a history of DCS involvement, and when she had her first baby, she was underage. So they had her listed as, oh, she's a runner, so we got to watch her closer. But her cord screen and her UDS came back negative. But then I had another mom who had been positive for cocaine throughout her whole pregnancy, but where she was an LPN, they looked at her differently because of her outside job. So they didn't follow protocol, just, like you would with any other patient. So it's they kind of pick and choose sometimes how they do treatment based on those outside factors.
Yep. Sad but true.
Yeah, exactly.
Yes.
I remember it.
Because once I get the mic, I keep talking, and so I talked a lot today, as I usually do, which means we've come to 1:15, which is the time I'm supposed to let you guys go. So we will see you again in a few months. We'll be sending you all emails about the upcoming session series that we're doing next. So pay attention to your inbox. Please, 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 please fill out your evaluation and the needs assessment so that we can put together content that you guys really want from us so that you continue to show up and participate. We love having you here. We love seeing your faces. We want to hear your stories. We want to hear what you're experiencing, the questions that you have. We are here to develop community and support, because the work we do is not easy work. But we need each and every one of you showing up every single day, taking care of the people that you take care of. So thank you very much for being here and for doing the work that you do. We appreciate it greatly. Take care all. Bye.
Thank you all.
Hey, Gary Jennings is